retina anatomy. It is a thin transparent membrane which extends from the optic disc to the ora serrata. It is divided into two distinct regions, the posterior pole, two regions, the posterior pole and the peripheral retina, which is separated by the retinal equator. Now, the retinal equator, posterior pole and peripheral retina is separated by the retinal equator. Retinal equator, it is an imaginary line which lies in line with the exit of the four vortex vein. This is a vortex vein. When we draw a line, imaginary line through the vortex vein, which is an imaginary line which lies in line with the exit of the four vortex vein. Now, posterior pole, it is best examined by slit lamp biomicroscope or direct ophthalmoscope. Coming to the parameters, optic disc, it is it is a circular area. It is this optic disc. It is a circular area about 1.5 mm in diameter. All the retinal layers terminate here except the nerve fiber layer. Now, the depression seen in the disc, this depression is known as a physiological cup. Then the central retinal artery and vein also emerge through the center of this cup. You can see. Then coming next is a macular lutea. It is a yellow. It is also called as a yellow spot. It is 5.5 mm in diameter. Macular lutea. It is of fovea centralis. It is about 1.5 mm. There is no rods here. Only cones are present which are tightly packed. It is a central depressed part of the macula. This is the fovea. See, this is the fovea which is 1.5 mm. And approximately one disc diopter 5 degrees subtensile angle of 5 degrees of visual field. Here fovea 1.5 mm, one disc diopter 5 degrees of visual field. Here cones are tightly packed. It is a central depressed part of the macula. This is a central, again fovea, this is a fovea. It is a central depressed part of the macula. It is a more sensitive part of the retina. Next is the foveola. Foveola, this is a fovea. See, this is a fovea, this whole circular, inside that is a foveola. Now, foveola is a point, it is a central shining pit in the fovea centralis. This is a foveola. Here. This is a foveola, it is a central shining pit in the fovea centralis. It is about 0.35 millimeter in diameter. It is situated 2 disc diopter, that is 3 millimeter away from the temporal margin of the optic disc. Only all the 10 layers of the retina is not present. Here the ILM is only present, and it is the thinnest part of the retina. Foveola, this is a foveola, 0.35 mm. Then here this is a fovea lay vascular zone. It is an area of about 0.8 mm, 0.8 mm, including foveola, which includes the foveola also, and the surrounding area which are devoid of retinal capillaries. Hence, it is known as the fovea lay vascular zone. Now, the peripheral retina, coming to the peripheral retina, it is best examined by indirect. This peripheral retina is best examined by IDO, by indirect ophthalmoscopy. There are three structures basically: pars plana, ora serrata, and vitreous base. Pars plana is see here the ciliary body. It starts about 1 millimeter from limbus. This is the ciliary body. This is the pars plana of the ciliary body. This part is a pars plana of the ciliary body, and this part is a pars plicata. This process is there. It is a pars plicata. It starts about 1 millimeter from the limbus, and it extends for about 6 mm. It extends for about 6 mm, and the first 2 mm contains the pars plicata. First 2 mm is the pars plicata, and the remaining 4 mm is the pars plana. It comprises a flattened pars plana. So, in order to not endanger the lens or retina, the optimal location for a pars plana surgical incision, like in cases of intravitreal injections and other surgical incision, we give incision in the pars plana so that the lens or the retina, no structures are injured. This is a pars plana. So, the common site for pars plana is 4 mm from limbus in phakic eyes and 3.5 mm from limbus in pseudophakic eyes. That is the farthest. This is at least 4 mm from limbus like in phakic eyes and 3.5 mm from limbus in pseudophakic eye. Intravitreal injections or incision should be done. Then ora serrata and vitreous base. This is a vitreous base here, where the retina attachment or attachment to the ora serrata. This is a vitreous base. It is a strongest attachment, one of the strongest attachment of the retina. Now, coming to the microscopic structure, we know that there are 10 layers of retina from outer to inner. There are 10 retinal layer from outer to inner. First one is a pigment epithelium. First one is a pigment epithelium. It is a single layer of cells containing pigment. This is a retinal pigment epithelium. It is a single layer of cell containing the pigments. It is firmly adherent to the underlying basal lamina, that is a Bruch's membrane of the choroid. Choroid Bruch's membrane is there, it is adherent to that. Then there comes a layer of rods and cones. Now there are about 120 million rods and 60 million cones. 120 million rods and 60 million cones, 120 million rods and 6.5 million cones. The rods contain the rhodopsin. Rods contain the rhodopsin pigment. It serve the peripheral vision and the scotopic vision, that is vision of low illumination, peripheral vision and scotopic vision. Cones is highly discriminative central vision, that is a photopic vision and color vision. That is a layer of rods and cones. There is 120 million rods and 6.5 million cones. Then comes the external limiting membrane. So this is external limiting membrane. External limiting membrane. Then outer nuclear layer, outer plexiform layer, inner nuclear layer. It consists of the bipolar cells. Here, this is a bipolar cell and the inner plexiform layer. Then the ganglion cell layer. It contains the ganglion cells. The ganglion cell layer, it contains the cell bodies of the ganglion cell. Then it contains two types of ganglion cells are there, midget ganglion cell and polysynaptic ganglion cell. Midget ganglion cells are present in the macular region and the polysynaptic are present in the peripheral retina. It is predominantly present in the peripheral retina. Then we have the nerve fiber layer. This is the retinal nerve fiber layer. And then the internal limiting membrane. See, it is basically the photoreceptors are there, bipolar cells are there, and the ganglion cells are there, and everything is anastomosis between these three cells. See, photoreceptor cell, then the photoreceptor nuclear is the outer nuclear layer. The synapse between the bipolar and the photoreceptor is known as the outer plexiform layer. The bipolar nucleus is known as the inner nuclear layer. The synapse between the bipolar and the ganglion cell is the inner plexiform. Then ganglion cell layer, altogether they goes to the optic disc by retinal nerve fiber layer and the internal limiting membrane. These three cells you remember, photoreceptor, bipolar, ganglion cells. Next is the blood supply. Blood supply, the outer 4 layers are supplied by the choroidal vessels, that is close to the choroid, and the outer 4 layers, and the inner 6 layers are supplied by the central retinal artery. This is the central retinal artery here, this one. This is the central retinal artery. Inner 6 layers are supplied by the central retinal artery. Coming to the congenital anomalies, here the coloboma of optic disc, first one is coloboma of the optic disc. It is typically inferior nasally. It is also known as the morning glory appearance. Morning glory. This is the morning glory flower. It has this particular morning glory. Morning glory appearance. This is the inferior nasal. See, this is the optic disc. You can see the coloboma here. This is the optic disc. You can see the coloboma here. Inferior nasal coloboma is a typical appearance. It is known as a morning glory appearance. That is the optic disc coloboma. Okay, optic disc coloboma. Then next congenital anomaly is the hypoplasia of optic disc. It has this double ring sign. This is the hypoplasia of optic disc. Double ring sign because of the hyperpigmentation and the scleral margin. We have this double ring sign in optic disc. A double ring sign, it is seen in hypoplasia of optic disc. Next is the drusense of optic disc. It is if it is children in if it is seen in children, this is a drusense. It is if it is in children, then it presents as pseudopapilledema. Then in teens, teenage, it is ophthalmoscopic, shows these waxy pea-like irregular refractile bodies. That is a drusense of optic disc. Next congenital anomaly is the persistent hyaloid artery. Now this is the Burgmeister's papillae. It is the most common congenital anomaly of the hyaloid system. This is the Burgmeister papillae. It is a remnant of posterior remnant of the hyaloid artery. This is the Burgmeister papillae. Then we have the Mittendorf sign, that is also a congenital anomaly due to the persistent hyaloid artery in the remnant of end of the hyaloid artery attached to the posterior lens capsule. This is the Mittendorf dot. Next is retinal hemorrhages. Coming to retinal hemorrhages, flame shaped hemorrhages are there, dot blot hemorrhages are there, and subhyaloid hemorrhages are there. Flame shaped hemorrhages, they are located within the nerve fiber layer, that is basically they are superficial. Okay. Nerve fiber layer, flame shaped, they are superficial, then it is located in the posterior pole. These are the flame shaped hemorrhages. These are the flame shaped hemorrhages. It resolves within a short period of time, around 6 weeks, because they are superficial and it resolves within a short period of time, around 6 weeks. It is associated with retinal vascular pathologies which affects the superficial and peripapillary beds. Okay, then Roth spot. This is a typical Roth spot. Okay, these are the typical Roth spot. It is also a flame shaped hemorrhages that has a white or pale center. So, this is a flame shaped hemorrhages with this white or pale center, that is Roth spot. Next is dot blot hemorrhages. Dot blot hemorrhages are located in the inner nucleus and the outer plexiform layer, that is basically it is in the deeper layer, it is deep. Then it takes longer to resolve. These are the dot blot hemorrhages. Here you can see the multiple dot blot hemorrhages you can see here. They take longer to resolve because of its location is deeper, it is located in the deeper layers. It is commonly associated with conditions like diabetic retinopathy, then vein occlusions or juxtafoveal retinal telangiectasia. Next is the subhyaloid hemorrhage. Subhyaloid hemorrhage is it is vitreous hemorrhage present in the subhyaloid space known as the pre-retinal hemorrhage. This is a subhyaloid hemorrhage. It is a board shaped and trapped in the it is board shaped because it is trapped in the potential space between the posterior hyaloid and the internal limiting membrane. Between the posterior hyaloid and internal limiting membrane. Next is a cotton wool spot. Cotton wool spot, these are the cotton wool spot. It is usually it is accumulation of neuronal debris within the nerve fiber layer. Look at the nerve fiber layer, neuronal debris, accumulation of neuronal debris. Next, coming to retinal artery occlusions. Now, retinal artery occlusions etiology, it is most commonly it is atherosclerosis. It is related to the thrombosis. It is mainly at the level of lamina cribrosa. See, it is here. This is the lamina cribrosa. It is mainly at the level of lamina cribrosa. This is the most common cause. Atherosclerosis due to thrombosis is the most common cause. It is the most common cause. Then emboli from carotid and cardiac origin can also be there. It can be due to cholesterol emboli, that is known as the Hollenhorst plaque. Or calcium emboli or platelet fibrin emboli. It causes retinal ischemic attack. This platelet fibrin emboli causes retinal ischemic attack. Then it can be also due to retinal arteritis. It is can be due to this polyarteritis nodosa, SLE, vaginous granulomatosis, scleroderma, etc. Then there can be other causes like thrombophilia, angiosperm, and rare causes like OCP, sickle cell anemia, polycythemia, Epler syndromes, etc. Now, clinical features, it is we are talking about retinal artery occlusion. Okay, clinical features, it is most commonly seen in males. It is seen in males. Mean age at onset of 60 years. Usually, it is unilateral. Then central retinal artery occlusion, obstruction is at the level of lamina cribrosa, that it's at the level of lamina cribrosa. Then the patient will complain of sudden painless loss of vision. There is no pain, sudden painless loss of vision, and there will be marked reduction in visual acuity, decreased visual acuity. There will be marked reduction in visual acuity, and there is absent pupillary reflex. That is, there is a total and profound efferent pupillary defect, that is known as the emerotic pupil. Efferent pupillary defect is totally lost. Then there is narrowing of the retinal arteries and mild narrowing of the retinal veins. Here you can see the retinal arteries are narrowed. Here there is narrowing of the retinal, there is marked narrowing of the retinal arteries. And there is the milky white retina. It is a milky white retina or cloudy white edematous ground glass retina. Because of edema, because of edema, the retina looks milky white and there is marked narrowing of retinal vessels. Then cherry red spot. There is a cherry red spot. Cherry red spot in the center of macula, and there is this cattle truck or boxcar. See cattle truck or boxcar appearance. Here we can see the cattle truck or boxcar appearance because of the segmentation of blood column in the retinal vein. Okay. This is a cattle truck or boxcar appearance. Then later on there can be atrophic changes, grossly attenuate thread-like arteries, and consecutively there can be optic atrophy also later on, later changes. Then rubeosus iridis, that is new, the vessels in iris. These are the rubeosus iridis. Usually normally there are the vessels are not tortuous, and rubeosus iridis occur typically earlier than in CRVO in CRAO. Here it occurs within 4 to weeks compared to CRVO which occurs in 3 months. Then FFA. See FFA you can see in if you take all the films in FFA, the choroidal phase and the AV phase and all, there will be delay in arterial filling in FFA, delay in arterial filling, and there will be masking of the choroidal vasculature. Here we can see the choroidal vasculatures are not visible. The choroidal vasculatures are not visible because of the retinal edema. Here in BRAO, the branch retinal artery occlusion, you can see BRAO usually occurs because of obstruction, due to obstruction and bifurcation. Now in CRAO, the no effective treatment available as of currently. So we can do like for immediate lowering of IOP, we can do it by intermittent ocular massage, then IV mannitol or acetazolamide, or topical epinephrine 1% or timolol 0.5%. Then paracentesis of anterior chamber can be done. For vasodilatation, we can give sublingual isosorbide dinitrate, rebreathing into a paper bag. Into a paper bag in order to elevate the blood carbon dioxide and causes respiratory acidosis. Then or inhalation of carbogen, it is the same as rebreathing into the paper bag, or Meduna's mixture, which is 95% of oxygen and 95% of oxygen and 5% of carbon dioxide. Then transluminal Nd:YAG laser embolysis or embolectomy can be done. Steroids is given in case of giant cell arteritis. Okay, steroids is given in case of giant cell arteritis. Complications include neovascular glaucoma, as rubeosus iridis is there. Because of the ischemia, rubeosus iridis will be there, and then which can eventually lead to glaucoma. Next is retinal vein occlusion. Retinal vein occlusion is more common than the retinal artery occlusion. It is seen in elderly patients in up to 6 to 7 decade. Etiology is mainly by, see there is etiology is that there is pressure on the vein by an atherosclerotic retinal artery. There is this pressure on the vein because so basically the atherosclerotic retinal artery. Then etiology, the other etiology is hypertension, diabetes mellitus, hyperviscosity of blood, which can be due to polycythemia, hyperlipidemia, multiple myeloma, cryoglobulinemia, macroglobulinemia. Then peripheral uveitis retina, it is associated with sarcoidosis, SLE, syphilis, etc. Now increased IOP can be a cause. Then local causes like orbital cellulitis, orbital tumors, facial erysipelas, cavernous sinus thrombosis can also be there. Now classification, it can be central retinal vein occlusion or branch retinal vein occlusion. Central can be non-ischemic CRVO, that is venous stasis retinopathy, and ischemic CRVO, that is hemorrhagic retinopathy. This is venous stasis. Ischemic is hemorrhagic. Non-ischemic CRVO, it is the most common type, and there is mild to moderate vision loss, and there is no RAPD. It is in contrary to the ischemic. Okay, the most common mild to moderate vision loss, no RAPD. On fundus examination, early stages we can see these mild venous congestions and tortuosity of the vessels. Then a few flame shaped hemorrhages can be seen, and mild papilledema. The mild congestion, venous congestion, toxicity, mild flame shaped hemorrhages, mild papilledema, mild or no macular edema can be seen. It is in the earliest stages. Late stages, like that is after 6 to 9 months, then we can see the sheathing around the main vessels. Then cilioretinal artery, we can see cilioretinal collaterals around the disc can be seen. Cystoid macular edema can be seen. 6 to 9 months, later stages. Sheathing around the main vein, cilioretinal collaterals around the disc, then cystoid macular edema. 50% of these cases will resolve spontaneously with normal vision. 50% will resolve spontaneously. In the rest, visual loss is due to the cystoid macular edema. Intravitreal triamcinolone acetonide is given for cystoid macular edema. Okay. For cystoid macular edema, we can give intravitreal triamcinolone. Now, for in ischemic CRVO, it is a acute complete occlusion of the central retinal vein. There is marked vision loss, and there is a relative afferent pupillary defect present. Visual field defect are also present. In ERG, there is reduced amplitude of B wave. Fundus examination, early stages we can see massive. This is a typical picture of a CRVO, ischemic CRVO, there is massive engorgement, congestion and tortuosity of the retinal vessels, the retinal veins. Here you can see the retinal veins. Then whole fundus is full of hemorrhage. It is typically known as this tomato splash or blood and thunder appearance. And then there are multiple cotton wool spots. Here you can see the cotton wool spots, multiple cotton wool spots, and marked macular hemorrhage and edema will be present. In late stages, there is marked sheathing around the veins and collaterals around the disc, neovascularization of the disc or neovascularization elsewhere. This in later stages. In later stages, it progresses to, because of the ischemia, it progresses to neovascularization of the disc, neovascularization elsewhere, that is at the periphery. Then marked pigmentary changes in the macula, cystoid macular edema. Complications include rubeosus iridis and neovascular glaucoma. This is a rubeosus iridis leading to neovascular glaucoma within 3 months. It is also known as a 100-day glaucoma. Other complications include vitreous hemorrhage, proliferative retinopathy, etc. Now, treatment basically depends if there are new vessels at the disc or new vessels elsewhere, indication for sector photocoagulation. We do a sector photocoagulation within the posterior segment. If there is neovascularization of the iris, then indication for urgent pan-retinal photocoagulation. Then intravitreal anti-VEGF agent is a treatment for macular edema secondary to BRVO. Secondary to BRVO. Then we can give intravitreal dexamethasone implant, micropulse laser, intravitreal triamcinolone can also be given. Next is Eales disease. It is an idiopathic occlusive peripheral phlebitis, also known as periphlebitis retinae. It is characterized by recurrent vitreous hemorrhages. Recurrent vitreous hemorrhage will be there. Usually bilateral disease. Bilateral, usually affect the young adult male. Now there will be inflammation. See, peripheral periphlebitis will be there. See, you can see the inflammation here. Peripheral periphlebitis. Common presenting feature is because of the vitreous hemorrhage, the patient will complain of sudden appearance of floaters. Floaters means black spots or painless loss of vision due to vitreous hemorrhage. Hemorrhage clears, but it will recur later on. CKLA's complication is retinal neovascularization, tractional RD, retinal detachment or tractional retinal detachment, rubeosis iridis and neovascular glaucoma. Next we will discuss about hypertensive retinopathy. Hypertensive retinopathy, normal ratio of artery to vein is 2:3. There is narrowing of arteries which occur in hypertensive retinopathy. Now, 3 factors play a role in the pathogenesis. First one is a vasoconstriction. Now, this is related to the severity of hypertension and occur in pure form in a young adult. Next is arteriosclerotic changes. It manifests as arteriolar reflex and AV nipping due to the thickening of the vessel. It reflects the duration of hypertension and it is typically seen in old patients. These changes pre-exist due to involutional sclerosis. Third one is the increase in vascular permeability. Now, grading, we will discuss about Keith and Wegener grade classification of hypertensive retinopathy. Grade 1, there is generalized arteriolar attenuation. And there is mild generalized arterial attenuation, broadening of the arterial light reflex and vein concealment. This is the arterial attenuation. Then in grade 2, there is generalized narrowing of the retinal arterioles, focal attenuation of arterioles and cellulosine, that is a S-shaped deflection of veins at the AV crossing. This is cellulosine, this is a S-shaped deflection of the, see here you can see the deflection of the veins at the AV crossing because of the arteriosclerotic vein. This is a normal AV crossing, and then in cellulosine there is deflection of the vein that is seen in grade 2. In grade 3, grade 2 changes plus there will be copper wiring of arteriole, gun sign. Grade 3 there will be cellulosine in grade 2, and in grade 3 there will be gun sign, bonus sign. Cotton wool spots, flame shaped hemorrhages, everything will be seen. Hard exudates, cotton wool spot. Gun sign is tapering of veins at the on either side of the AV crossing. Bond sign is banging of the distal BV. You can remember banging of the veins distal to AV crossing. And then in grade 3 there will be cotton wool spots, hard exudates, superficial flame shaped hemorrhages, etc. In grade 4 it includes grade 3 changes plus papilledema and silver wiring of arterioles. In retinopathy in pregnancy induced hypertension, it is usually seen, retinal changes are seen when the blood pressure rises above 160 by 100 millimeter mercury. Changes are marked when blood pressure is above 200 or 130, 200 to 130 millimeter mercury marked. Fundus examination, earliest changes narrowing of nasal arterioles, then later there is generalized narrowing of the arterioles. Cotton wool spots, retinal edema, same we can say cotton wool spot, retinal edema. Here there is macular star, here macular star or flat macular detachment can be seen, macular star can be seen here. It can later on lead to macular star. Prognosis for retinal reattachment is good, which occurs spontaneously within a few days of termination of pregnancy. Next is hypertensive choroidopathy. Here there is Elschnick's, it can be, there are 2 type forms, Elschnick spots. These are focal choroidal infarcts. Here these focal choroidal infarcts seen as small black spots surrounded by yellow halos. Yes, here these yellow black spots with yellow halos, these are Elschnick spots. Then it can be, there is a Seeger streak. These are indicative of fibrinoid necrosis. Okay. Next we will discuss diabetic retinopathy. Diabetic retinopathy risk factor, duration of diabetes is the most important determining factor. If 50% develop diabetic retinopathy after 10 years, 70% after 20 years and 90% after 30 years of the onset of disease, it is more common in females. Then hypertension and pregnancy accelerates the changes of diabetic retinopathy. Morphology. Now, pathogenesis, basically there is thickening of the capillary basement membrane. See, this is a normal endothelial cell surrounded by the pericyte. There is thickening of these basement membrane, the increased thickening of the basement membrane Then capillary endothelial cell damage will be the cell loss will be the RBC. There will be deformation and increased stickiness of platelet, increased plasma viscosity and loss of these pericytes can also be there. These lead to these are the pathogenesis morphology. Then coming to the stages. Now non-proliferative and proliferative is there. In non-proliferative diabetic retinopathy, it is characterized by mild classification of diabetic retinopathy, that is it is based on the ETDRS classification system, early treatment of diabetic retinopathy study. It is non-proliferative, it is classified into non-proliferative and proliferative. In non-proliferative diabetic retinopathy, mild, there is microaneurysms, hard exudate and retinal hemorrhages in 1 or 2 quadrants. These are microaneurysms and hard exudates. In moderate, there is microaneurysm and hard exudates in 3 quadrants, and cotton wool spots and venous bleeding may be present. In severe, there is in severe we have the 4:2:1 rule, that is microaneurysm, retinal hemorrhages and hard exudates in 4 quadrants, cotton wool spots and venous bleeding in more than 2 quadrants, and intraretinal microvascular abnormalities, that is IRMA, in 1 quadrant. This is a picture showing early mild NPDR with only microaneurysms and hard exudates in 1 or 2 quadrant, moderate NPDR in 3 quadrants, then severe NPDR where there will be microvenous bleeding and there is venous bleeding and intraretinal IRMA should be there. 4 is to be venous bleeding in 2 quadrants and IRMA in 1 quadrant. Here again you can see the venous IRMA, intraretinal microvascular abnormalities, and the venous bleeding can be seen here in this picture. Now in proliferative diabetic retinopathy, the PDR is characterized by the proliferation of new vessel, that is neovascularization of the optic disc or elsewhere. This is a subhyaloid hemorrhage, vitreous hemorrhage, neovascularization of the disc or elsewhere. Now ophthalmoscopy, direct ophthalmoscopy or indirect anything else. In ophthalmoscopy, if we see, there will be loss of foveal counter. The foveal counter will be lost and there will be retinal thickening, and there is it is known as a honeycomb appearance of the macula due to the deposition of hard exudates. There is the honeycomb deposition of the appearance of the macula. In fluorescent angiography, there is flower petal appearance. Here there is a flower petal appearance in fluorescent angiography. There is a honeycomb appearance. Honeycomb appearance in macula, flower petal appearance in fluorescent angiography. Then in OCT, optical coherence tomography, this is the normal OCT, and in diabetic retinopathy there can be loss of foveal depression, then retinal thickening, intraretinal area of decreased reflectivity, and round optically clear region. There can be intraretinal cystine, cystine macular edema. See, this is the loss of foveal contour in diabetic retinopathy in OCT. Next is solar retinopathy. Solar retinopathy is it is also known as photoretinitis or eclipse retinopathy. It is like after watching sun during eclipse without protection, or watching bright sunlight, or exposure to bright flash of circuit, that is a welding arc. This can occur. The infrared radiations are absorbed by the pigmentary epithelium of the retina. It will result in paramacular burns. Here you can see these burns. It will result in paramacular burns. There is no latent period, and there is persistent negative after image, progressing to later on it will progress to positive scotoma and metamorphopsia. Later on there will be positive scotoma and metamorphopsia. No treatment is effective and it has a guarded prognosis. Next is central serous chorioretinopathy. This is a spontaneous serous detachment of the neurosensory retina in the macular region. It is usually seen in males 20 to 40 years, type A personality. There is sudden painless vision loss, painless loss of vision, and there is relative positive scotoma, micropsia and metamorphopsia. See, positive, this is a positive scotoma, like the patient will see a black color in the site. In negative scotoma is when the examiner identifies there is a loss of vision and there is enlargement of the blind spot. Now there will be micropsia. Because of edema, the cells are gone farther away, so the image will fall in less number of cells, so the image will look smaller. There will be micropsia, and there is distortion like this. This is a metamorphopsia, distortion in lines that will be seen in CSR. And ophthalmoscopy, there will be mild elevation of the macular area. This is known as a circular ring reflex. Here there will be circular ring reflex on ophthalmoscopic examination. Small yellow grey elevations due to RP detachment will be there, and fovea reflex will be absent because it is elevated. There is no foveal reflex absent or distorted. Usually it is self-limited, but often it will recur. On FFA, there is a characteristic smokestack pattern and the ink blot pattern seen in CSR. Next is sickle cell retinopathy. Sickle cell retinopathy is peripheral retinal neovascularization. There can be vitreous hemorrhages, then fibrovascular proliferation in the superior temporal periphery like C-FANCY. These are the manifestations in sickle cell retinopathy. There will be salmon patch. This is a salmon patch. These are intraretinal hemorrhages following peripheral retinal arterial occlusion. This is a salmon patch. And then there will be black sunburst appearance, black sunburst. These are coronal because of the focal retinal pigmentary epithelial hypertrophy, RP proliferation due to old hemorrhages. There will be black sunburst appearance. Due to intraretinal hemorrhages, there can be salmon patch. Then C-FAN appearance is because of the peripheral neovascularization. Usually fibrovascular proliferation is in the superior temporal periphery. It is known as a C-FAN. Then there can be a refractile spot, that is the old resorbed hemorrhages. See, this is a salmon patch, intraretinal hemorrhages. Old resorbed hemorrhages can later on lead to refractile spot. Then sunburst appearance. Then peripheral neovascularization and proliferation. Vitreous hemorrhages can be there. Basically, it is peripheral retinal neovascularization. So all the manifestations of neovascularization will be there. There can be there can also be CRAO, CRVO, angioid streak, tractional retinal detachment later on can be seen. Next is ARMD. Now ARMD, it is more common in people over the age of 65 years. Whites and female it is seen. Smoking doubles the risk and aspirin increases the risk. Now, does not cause blindness as it does not affect the peripheral vision. Now, it is of two types: dry, atrophic, non-exudative or non-neovascular type. 90% of the patients, this is the most common. Then next is the wet neovascular or exudative type. Now, this non-neovascular, dry ARMD. There is gradual diminution of vision, and in ophthalmoscope they will see drusen's and RP, loss of pigment in the retina and pigment epithelium. It is characterized by drusen. In the early and intermediate phase there is drusen and lipofuscin accumulation. In the late phase there is RP atrophy and geographical atrophy. In between the RP layer and the Bruch's membrane there is drusen deposition. This is the geographic atrophy. We can say it is seen in the later stages. Now, wet or exudative, there can be choroidal neovascularization, polyporoidal choroidal vasculopathy and retinal angiopatosis proliferans. As of now, these are considered as separate entities. This we will see later. Now, choroidal neovascularization, there can be drusen, lipofuscin accumulation, then choroidal neovascularization development occurs. Hemorrhages will be there. Later on, it can lead to scarring, that is deciform scarring. Now, there is occult there is classic CNV and the occult CNV based on FFA. See, classic CNV is early hyperfluorescence with well defined lacy patterns with progressive leakage. These are the lacy patterns. They have these progressive leakage will be there. Early hyperfluorescence. Now, occult is late leakage of either it will be fibrovascular PED, fibrovascular pigment epithelial detachment. You can see the fibrovascular pigment epithelial detachment, or it can be late leakage of unknown source, late leakage of undetermined source of or fibro. That is the occult CNV. Now that is one classification, classic CNV or occult CNV, FFA class. Then another classification is it can be either subfovea, that is involving the center of fovea. See here, it is either involving the center of the fovea or juxtafovea, that is between 1 to 199 micrometers from the center of the fovea, or it can be extrafovea, that is at least 200 micrometers from the center of the fovea. That is another classification, subfovea, juxtafovea and extrafovea. Now management of dry ARMD is mostly conservative, low vision aids, antioxidants can be given, vitamin C and D, zinc, copper, lutein and zeaxanthin. In wet ARMD management is basically the first choice was anti-VEGF, followed by, if not improving, then photodynamic therapy and transpupillary thermotherapy. See, this is a picture showing choroidal neovascularization, drusen formation and the membrane is damaged and the vessels are formed there. See, choroidal neovascularization, there is growth into the subretinal space leading to hemorrhages. Fibrovascular complex form known as the choroidal neovascular membrane. There is occult CNVM and classic CNVM. See, occult is in sub-RP space and classic is in subretinal space. See, this is a sub-RP space, sub-RP, below the RP. The subretinal fluid is this here, this is a subretinal space in between the RP. Sub-RP is in between the RP and the Bruch's membrane, subretinal is in between the RPE and the neurosensory layer. So, in occult CNV, which is sub-RPE, the investigation of choice is ICG. In classic CNVM, in subretinal space, the investigation of choice is FFA. Next one is epiretinal membrane. Now, epiretinal membrane, the cause is idiopathic, mostly posterior vitreous detachment. Causes idiopathic posterior vitreous detachment. Then usually retinal detachment surgery is the most common secondary cause, and other causes are also there like retinal break, panretinal photocoagulation, then retinal cryotherapy, retinal breaks, panretinal photocoagulation, retinal cryotherapy and retinal vascular disease, inflammation, trauma. Clinical features, there is an see here we can see an irregular translucent sheath. It is all it is known as cellophane maculopathy. It is present in early stages, this translucent sheath. Later on, as the membrane thickens, it contracts and becomes more obvious, that is a macula pucker. Here this macula pucker will be seen as the membrane thickens and contract. It is seen in the later stages. Next, we will discuss retinal detachment. Retinal detachment is a separation of neurosensory retina from the pigment epithelium. Here this is RP and this is a neurosensory retina. Separation of neurosensory retina from the pigment epithelium is known as retinal detachment. Now, it can be rhegmatogenous, exudative or tractional. First, we will discuss rhegmatogenous retinal detachment. Now, it is always due to retinal breaks or holes will be there, and through which the subretinal fluid seeps and cause RD. See here, there will be retinal tear or hole and the fluid seeps through it and causes retinal tractional RD. Rhegmatogenous RD. It is more commonly in male and in males 4 to 50 years, 40 to 60 years. It is more common in males 40 to 60 years. And 40% of cases are seen in myopics. Now, retinal degenerations will be there. Mostly it is under retinal degeneration like the lattice degeneration, this is the lattice degeneration or the snail track degenerations. Trauma and cataract surgery are the other predisposing factors. Final shape and position of RD is determined by the location of the retinal plaque, that is based on the Linkoff rule. Clinical features, the prodromal symptoms include flashing lights, floaters and photopsia. Localized relative loss in the field of vision of detached retina. and there will be sudden painless loss of vision. The patient usually complains of curtain falling sensation or a dark cloud, like that. There can be associated Marcus gun or RAPD, Marcus gun pupil. Intraocular pressure is usually lower by about less than 5 mm when compared to the other eye. Compared to other eye, usually it is lower due to the RD. Now in distant direct ophthalmoscope, it reveals a greyish reflex. Normally this is a normal. Normally there should be a red reflex. In the quadrant of retinal detachment, there is a greyish reflex. The normal red reflex is lost because of detachment. Now RD is best examined by indirect ophthalmoscope. Pigment, then another sign is the Schaffer's sign or tobacco dusting. That is pigment in the anterior vitreous is usually present. Then retinal breaks are usually present in the upper temporal quadrant. Now to differentiate between fresh RD and old RD, fresh RDs are usually detached and has a convex. See, it has a convex configuration and surface is corrugated, and subretinal fluid extends up to ora serrata, except in rare cases caused by a macular hole. B-scan ultrasonography. B-scan shows good mobility of the retina and the vitreous. In case of fresh RD, there will be good mobility. In old RD, there is retinal thinning due to atrophy, and there is formation of subretinal demarcation line. These demarcation lines are formed, high watermarks. In very old RD, secondary to intraretinal cyst can also be there. Secondary intraretinal cyst can also be there in very old RD. ERG can be subnormal or absent, and ultrasound is used to confirm the diagnosis. Complication include proliferative vitreoretinopathy. This is the most common complication. Others include cataract, complicated cataract, and later on it can lead to phthisis bulbi. Treatment. Now the surgical goal of the treatment is closure of all the retinal breaks with minimum iatrogenic damage. We can give cryotherapy or laser around the edges of the breaks, which results in adhesion. It will cause adhesions around the edges of the break if we give that. Then cryotherapy can also be given for treatment of detachment. Then subretinal fluid drainage can be done. To maintain the chorioretinal apposition, we can scleral buckling can be done, that is inward indentation of sclera to provide external tamponade. This is scleral buckling. A silicone band is used to provide this inward indentation to provide external tamponade. We give this scleral buckling can be done. Then pneumatic retinopexy can also be done. It is a expanding gas or bubble. It is a simple OP procedure to fix a fresh superior RD. Usually it is given in case of superior RD with 1 or 2 holes extending over less than 1 clock hour in the upper 2/3 of the peripheral cornea, less than 1 clock hour. Okay. After sealing breaks with cryopexy, an expanding gas bubble, that is sulfur hexafluoride or perfluoropropane C3F8 gas is injected into the vitreous. See, if there is a retinal break here, and the displaced fluid in this, the displaced fluid in the vitreous cavity, we give a gas bubble. Now this will cause pressure tamponating effect. Other treatments include pars plana vitrectomy, endolaser photocoagulation, and internal tamponade for all tractional RDs, and this is done when PVR is present. Pars plana vitrectomy. Next is exudative RD. Exudative RD, it is retina is pushed away from its bed by accumulation of fluid or neoplasm. See, this is the regmatogenous RD where there is break in the retina and fluid builds up behind the retina which is broken. In detached, this is a tractional. In exudative RD, fluid builds up behind in retina which is not broken. Retina is pushed away from its blood by the accumulation of fluid or neoplasm. Other systemic disease, there can be association with other systemic disease like toxemia of pregnancy, renal hypertension, blood discresis, or polyarthritis nodosa, etc. Then ocular disease, it can be due to congenital anomalies like nanophthalmus, optic pit, choroidal coloboma, familial exudative vitreoretinopathy. Then inflammatory conditions like Harada syndrome, is very important. Harada's disease, sympathetic ophthalmitis, posterior scleritis, sympathetic ophthalmitis, or orbital cellulitis also really. Then vascular disease like Coats disease, exudative retinopathy, CSR, neoplasms like malignant melanoma of choroid, exophytic retinoblastoma. Then sudden hypertonia due to perforation of globe or intraocular operations. Due to perforations. Sudden hypotonia due to perforation. UVL effusion syndrome, that is a bilateral detachment of the choroid, ciliary body and retina. Now, to differentiate it from tractional, other RD from rhegmatogenous RD, there is absence of photopsia. In exudative RD, there is absence of photopsia, holes, tears, folds or undulations. Then floaters may be present. A visual field defect may develop suddenly and progress rapidly. Then configuration of detached retina is concave. There it was convex, here it is concave and smooth. Concave and smooth, the surface is smooth. The detached retina is freely mobile, and the shifting fluid, that is here, see in exudative RD, here the collection of the inferior collection of subretinal fluid when the patient was sitting, and then the subretinal fluid shift upward when the patient assumes the supine position. The shifting fluid when the shifting fluid changing its position with gravity is a hallmark of exudative RD, shifting fluid. Then on transillumination, rhegmatogenous RD is transparent while exudative RD is opaque. Rhegmatogenous RD is transparent while this exudative RD is opaque. Next is tractional RD. Tractional RD, retina mechanically pulled away from by the contraction fibrous tissue in the vitreous. This is a tractional RD. Because of the fibrous tissue mechanically pulls away the retina. These are known as the vitreoretinal tractional bands. These vitreoretinal traction bands will pull the retina. It is following it can be following penetrating injuries, proliferative diabetic retinopathy, retinopathy of prematurity, plastic cyclitis, that is cyclitic membrane, sickle cell retinopathy, Eales disease, incontinentia pigmenti, or toxocariasis. Then here photopsia and floaters are absent. The visual field defect usually progress slowly and may be stable for months or even years. Configuration of detached retina is concave. It is concave, okay. Concave in configuration. Retinal breaks are absent. To differentiate it from rhegmatogenous RD, retinal mobility is severely reduced and shifting fluid is absent. Now, subretinal fluid is shallower than in the rhegmatogenous RD and seldom extend to the ora serrata. Highest elevation of the retina occurs at the site of the traction, that is the highest elevation. Treatment is for everything pars plana vitrectomy. Next is retina in HIV infections. Now, there will be multiple cotton wool spot which occur in about 50% of the cases. There will be cotton wool spots, and retinal hemorrhages will be also there. Hemorrhages will be also there in approximately 15 to 40% of the cases. Microaneurysm and telangiectasia are also seen. First one is CMV retinitis and toxoplasmosis. CMV retinitis is usually seen when the CD4 count is less than 100 millimeter cube, and toxoplasmosis is usually seen when the CD4 count is less than 250. Now coming to toxoplasmosis, there is a triad where this including convulsions, chorioretinitis and intracranial calcifications. There will be satellite lesions. These are the satellite lesions in chorioretinitis. This is mainly satellite lesion, and there is a typical headlight in fog appearance. This is a headlight in fog appearance due to the intense vitritis. This is a satellite lesion here. Satellite lesion. Then in CMV retinitis, the most common, CMV is the most common cause of chorioretinitis seen in immunocompromised patients. The patient will have these characteristics of crumbled cheese. It is typical because of the hard exudates and the hemorrhages. There are a lot of extensive hard exudates and hemorrhages. It is known as crumbled cheese and ketchup or pizza pie appearance of the retina. Brush fire appearance is also there. It is similar because of the hard exudates and the hemorrhages. Then retinal necrosis and optic neuritis can be seen, and there is this frosted branch angiitis, and immune recovery uveitis is also seen. Next is, this is a frosted branch angiitis seen in CMV retinitis. Next is acute retinal necrosis. Then acute retinal necrosis, this areas of retinal necrosis. Here, varicella zoster, it is due to varicella zoster virus is the most common. It is the most common typically in older patients. Herpes simplex virus 1 and 2 typically cause AR in younger patients. Next is retinitis pigmentosa. Retinitis pigmentosa, it is a pigmentary retinal dystrophy, predominantly affects rods more than cones. And it can be sporadic, autosomal recessive, autosomal dominant, X-linked recessive, out of which X-linked cases are the most severe. X-linked are the most severe. Now males are more affected, and invariably it is bilateral. Usually begins in childhood and often results in blindness in middle or advanced stages. There will be blindness. By middle or advanced stages, patient will be blind. The night blindness is a characteristic feature. It is due to the degeneration of rods. Tubular vision is seen in advanced cases. Only later on, this is tubular vision is seen only in advanced cases. Now light threshold of peripheral retina is increased and dark adaptation is not affected until very late. Okay. Then there is retinal pigmentary changes. It resembles the bony corpuscles with spidery outline, typically perivascular. These are the manifestations where you can see the retinal pigmentary changes. Pigmentary bone spicules can be seen here. So pigmentary bone spicules. Then regeneration starts in a zone near equator and spreads both. It starts in a zone near equator and spreads both anteriorly and posteriorly. Attenuation, narrowing of the retinal arterioles can be seen, and then optic disc consecutive optic atrophy will be there. That is pale and waxy optic disc. Here consecutive pale optic disc and retinal pigmentary the changes will be there, and the retinal arterial attenuation will be there. Same attenuated retinal artery, pale waxy pallor optic disc because of consecutive atrophy of the optic disc. Then bony corpuscle pigmentation will be present. Bony corpuscle pigmentation will also be present. Now there is annular or ring shaped scotoma in the typical visual. This is the annular or ring shaped scotoma in the visual field defects. It is seen in later stages only. Okay. Later only central this vision is left, that is a tubular vision. This is a tubular vision. Annular ring shaped scotoma is present in the initial phase. ERG, it is sensitive diagnostic test. It is abnormal or abolished. This is a normal ERG. See, this is a normal ERG, and in RP you can see a diminished ERG. Here now the scotopic will be affected before the scotopic will be affected before photopic, and that is night vision will be affected before earlier, and B waves affected before the A wave. In electrooculography, that is EOG, there is absence of light peak. Then syndromes, then there are atypical forms, that is retinitis sign pigmento or pigmentosa sign pigmento. Here all features of RP is present except visible pigmentary. This pigmentary changes is not present. Changes in fundus is not present, other than that all the features are present. Sectoral RP is involvement of one sector of retina. Pericentric RP's pigmentary changes are confined to an area immediately around the macula. Again, retinitis punctata albicans, it is innumerable discrete white dots. Instead of that black corpuscles, we can see white dots scattered in the fundus. No pigmentary changes will be there. Now, syndromes associated with retinitis pigmentosa. Refsum syndrome, there will be peripheral neuropathy. Plus cerebellar ataxia. In Usher syndrome, there is labyrinthine deafness. Plus premature aging. Mental retardation, skeletal anomalies. In Lawrence-Moon-Biddle syndrome, there is obesity, polydactyly, mental retardation. In Cookien syndrome, there is progressive infantile deafness, dwarfism, nystagmus, ataxia, and mental retardation. In Hallgren syndrome, there is vestibulocerebellar ataxia, congenital deafness, and mental retardation. Friedreich's ataxia and Kearns-Sayre syndrome are the other two syndromes associated with retinitis pigmentosa.